Okay, good morning, everybody. It's a privilege to be back here. This is a very important awareness program that NYU combined with the Bigganes are generously hosting, and we're glad to see so many of you here today. So I'm a dermatologist who did fellowship training in skin cancer surgery, and about half of my practice is devoted to treatment and, well, detection and treatment of skin cancer. The other half is more treatment of sun damage and aged, photo-aged skin. So hopefully I can share some of my experience and knowledge with you today. So as far as an introduction to skin cancer, as you heard in the video, skin cancer is the single most common form of cancer diagnosed in the United States. It's estimated that more than 3.5 million new cases in over 2 million people will be diagnosed this year. And we think this is probably even a gross underestimation because so many of the less aggressive types of skin cancer, which I'll talk about, are often not even reported because they don't need to be reported. So we think that 3.5 million might even be a gross underestimation. There will be more new cases of skin cancer than the other cancers that we consider very common: breast, prostate, lung, and colon. There are more new cases of skin cancer than all of those combined. So it's really important to be aware of it. It's thought that 1 in 5 Americans will develop some form of skin cancer at some point in their lifetime, and that actually includes patients of all skin types. So this includes African Americans, Latinos, Asian Americans. So it's clearly higher in light-skinned patients, Caucasians who've had significant sun exposure. But the point is, and as we saw in the video, melanoma can really affect all skin types, so everybody needs to be aware of it. There are multiple types of skin cancers, but the 3 main types and the ones that I see every day in my practice are basal cell carcinoma, squamous cell carcinoma, and of course melanoma, which is the one that you'll hear more about later today. I'll talk about at the end of my talk because it is the most serious and therefore the most important. But something that's interesting to point out, most skin cancers are not melanoma. They're actually what we call non-melanoma skin cancer. I'm sure, I won't ask you to raise your hand, I'm sure there are people in this room that have been afflicted by either basal cell carcinoma, squamous cell carcinoma. Those are the 2 most common types. So it's thought that about 80% of all new skin cancers are basal cell carcinoma, about 16% are squamous cell carcinoma, and about 4% are melanoma. It's thought that in this year, more than 12,000 people will die from skin cancer, with at least 75% or 3/4 of those being from melanoma. So what's important to point out is that although melanoma only comprises about 4% of new cases of skin cancer, it accounts for more than 75% of skin cancer-related deaths. So clearly it's the most aggressive, and this is why early detection is so important and why we need to know what to look for and what you all need to know what to look for. So again, non-melanoma skin cancer, incredibly common, representing half of all cancers diagnosed in this country. So when we hear non-melanoma skin cancer, again, we're talking about basal and squamous cell carcinoma. It's thought now that about half of all Americans, again, all skin types, but all Americans who live to age 65 will have basal or squamous cell carcinoma at least once. The good news is both basal and squamous cell carcinoma have a better than 95% cure rate when they're detected and treated early. So these are not very aggressive cancers, but they should be treated, and I'll show you some pictures. If they're left untreated, they can cause problems, and they can metastasize, although a much lower chance of that than melanoma. The mortality is thought to be about 1 to 2% when you're talking about non-melanoma skin cancer, and the majority of those are metastatic squamous cell carcinoma. So basal cell, which represents about 80% of skin cancers, has virtually 0% chance of metastasizing and a very low chance of ever killing you. But again, we like to treat them because they can be disfiguring if they're left untreated. As far as risk factors, again, now we're talking about non-melanoma skin cancer because the risk factors are different when it comes to melanoma. But the prevalence and incidence of basal and squamous cell cancer varies with several factors. We know with these types of skin cancers, it's cumulative sun exposure that's important. So older people tend to get these more than younger people. They tend to occur mostly on sun-exposed areas. We know that the sun is a major factor for basal and squamous cell carcinoma. So they tend to occur on the head, the neck, areas like the backs of the hands and the ears that are exposed 365 days a year have a very high chance of squamous cell carcinoma, which is very directly correlated with chronic sun exposure. And in this type of skin cancer, although we are seeing it in all skin types, It certainly is more likely to occur in fair-skinned patients with light-colored eyes and with red or blonde hair, because they don't have as much protective melanin, so they are more prone to the damaging effects of UV radiation. So basal cell carcinoma, again, represents 80% of all skin cancers, and that makes it the most common cancer, period. So it's more common than, breast, prostate, lung, colon combined. It's more common than thyroid. It's by far the most common cancer diagnosed. Again, it has a virtually zero chance of metastasizing. It has been reported, but in very rare situations. But it can be disfiguring, and it can invade local tissue. So for example, they're very common on the nose, and if left untreated, they can start eating away at the skin and eventually the underlying muscle and cartilage. So they can cause problems, although they're rarely life-threatening. Interestingly, although we used to think of basal and squamous cell cancers occurring almost exclusively in older people, we're seeing a lot more of these in younger people. We think some of this, as I'll touch on later, is related to the whole tanning and the whole tanning industry, indoor tanning and outdoor tanning. So the number of women under age 40 diagnosed with basal cell carcinoma has more than doubled in the last 30 years. My fellowship training was in something called Mohs surgery, and some of my lovely nurses are here in the back, but they can attest to the fact that the patients we do Mohs surgery on has definitely gotten younger and younger, and we do Mohs surgery on patients under 40 all the time. So it's definitely getting more common. As far as the clinical presentation, so basal cell cancer often occurs what we call as a pearly papule. So the skin is sort of shiny or translucent, like a pearl. It oftentimes has a rolled border and then a crusted indentation in the middle. I don't know if you can see the pointer actually, but so you see often a raised border with a little indentation in the middle. And as the growth enlarges, it starts to develop what's called telangiectasias, or broken blood vessels on the surface. And these are more classic textbook examples, but again, they tend to be kind of shiny with enlarged blood vessels on the surface. They often occur, like a patient will come in and say, I've had this pimple. As I mentioned, they're very common on the nose, on the forehead, on the face, chronically sun-exposed areas. So patients often come in and say, I have a pimple that hasn't gone away, or maybe a shaving cut that doesn't heal. Like, these are often signs of a non-melanoma skin cancer. Again, any kind of sore, a shaving cut or a sore that bleeds and is non-healing, that could be an indication that there is a basal cell cancer there and that a biopsy should be performed to establish the diagnosis. There's one rare type worth mentioning called morpheaform basal cell carcinoma. These are harder to see. They often appear like a scar on the skin, a cicatrix or a scar. They tend to be very poorly defined, meaning you can't exactly delineate them from the normal skin. But the classic presentation here is the patient might have a scar, and when you ask them how they got that scar, there was no history of trauma before, they didn't have any injury. So this is, again, a rare type of basal cell, but it does indicate the presence of a more aggressive tumor, because this type tends to go on much broader and much deeper than how it appears on the skin. And then I mentioned, and I'm sorry, I know these pictures can be disturbing, but these are neglected basal cell cancers. So we don't see these as much anymore because the awareness is out and people do tend to come in with tiny little spots. But this is why, because often I hear a patient will say, well, if it's never going to kill me, why bother having surgery? Why bother cutting it out? And if left alone, they can start to invade tissue and they can be disfiguring. So we don't see those much anymore, thankfully. The second most common type of skin cancer is called squamous cell carcinoma. This is the type that's most directly correlated with chronic sun exposure. So something that's interesting is people who work outdoors, not so much in New York City, but like farmers in the Midwest who are outdoors every day, day in, day out, they get a ton of squamous cell carcinomas. They actually get less melanoma. So it's actually interesting and suggests something about the types of ultraviolet exposure that one gets. And I'll touch on that later when I talk about melanoma. But this is the one that occurs almost exclusively on sun-exposed areas and areas that are exposed chronically. So again, I mentioned the ears, the lips, the backs of the hands, the scalp, as men tend to lose their hair. They're very common. It also can occur more rarely in association with injuries like burn injuries, scars, and the same virus that causes warts, it has been associated with that as well. So HPV virus, which can cause cervical cancer, has also been reported to be associated with squamous cell carcinoma. Unlike basal cell, squamous cell carcinoma has moderate metastatic potential, so it's very rare that they do metastasize, but if left alone and if untreated, they do have potential to spread. Not nearly as aggressive as melanoma, which we'll talk about, But basal cell, we usually say virtually never spreads. Squamous cell, if left alone, can definitely metastasize to the local lymph nodes and then more diffusely. So all the more reason to treat them early. These present a little bit differently from basal cell. They tend to be scaly or thick-skinned. Some people describe them as looking kind of wart-like, because they tend to be crusty or scaly. Again, they do tend to occur on areas like the ear and the lip, which are exposed 365 days a year. The lower lip is a very common place for squamous cell carcinoma due to chronic sun exposure. Cigarette smokers also are at greater risk for squamous cell carcinoma as well. So the combination of the sun and the cigarettes on the lower lip make it a very high-risk area. And these two areas do have a higher chance for metastasis than one on the body would, for example, because there's such a good blood supply, so the cancer has easy access to get into the blood vessels or the lymphatics. Again, we use the dermatologic term for this is hyperkeratotic. It basically means because cancers tend to proliferate very rapidly, the skin is turning over very quickly, and therefore the epidermis is proliferating rapidly and causing these thick, scaly growths. So when you see a squamous cell carcinoma, they tend to originate on the outer layer of the skin, and it tends to get very thick and scaly and almost horn-like or wart-like. Again, chronic scaling. This one, unlike the cut that doesn't heal that we talked about for basal cell, with squamous cell carcinoma, patients will often say, I have this patch of dry skin that doesn't go away, or this, this scaly patch that's been here for months or years. That's an indication that this lesion might be a squamous cell carcinoma. Again, though, an open sore that bleeds and crusts. This is called subungual squamous cell carcinoma here. It's a very aggressive type because they tend to get diagnosed much later. People tend to ignore things going on under their nails. Interestingly, though, recently there have been some studies suggesting that those high-pressure UV, the UV gel that people use when they get manicures, and they're putting their hands under that intense UV light sometimes every week, there's definitely been a higher incidence of subungual squamous cell carcinoma and squamous cells on the backs of the hands as well. So we encourage people to be aware of that and to take precautions. Again, when left untreated, usually this is Manhattan. People have a high awareness. They come in with like these little skin cancers. But if they're left alone, and I've definitely seen some of these in my practice, if someone neglects their basal or squamous cell carcinoma, they can look pretty ugly. And they should be treated before they get to this point, hopefully. Just one word. Again, I'm certain people in this room have actinic keratoses, whether or not they know about it. But actinic keratosis is the single most frequent reason for visiting a dermatologist. These are thought of as precancerous lesions. They tend to occur in people that have a lot of sun exposure. And if left alone, about 8% of them, it's thought, can progress to become squamous cell carcinoma. So actinic keratosis is when, if you looked under the microscope, you'd see atypical cells, but only like partial thickness of the skin is atypical. Once it progresses to full-blown atypia, that's when it might be a squamous cell carcinoma. So it's best to treat these when they're still precancers because they're very easy to cure. Most importantly, though, people that get a lot of these AKs it's a marker that they are at high risk for developing other types of skin cancer, because the people that get these tend to have spent a lot of time in the sun. They usually are lighter skin, although again, we're starting to see these in all skin types as well. But if you see people with a lot of AKs, it's a good indicator that they're likely to develop skin cancer. As far as how these present, these can be very subtle. Oftentimes we actually feel these without seeing them. So when I'm doing a skin examination, at the end of the exam, will often take my gloves off and feel the scalp, which is a very high-risk area, the ears, the backs of the hands, because sometimes you can actually, again, I'm sorry because this pointer is not so great, but you can sort of make out these ill-defined scaly patches. The patient often comes in and says, I've been feeling roughness up there, so that's, again, an actinic keratosis. Again, because they are directly correlated with sun exposure and with chronic sun exposure, they do tend to occur in areas that are exposed every day. And this is why, as dermatologists, we really emphasize daily sun protection. It's not just about going to the beach. It's really on all of your exposed areas, keeping a hat on, sunglasses, a moisturizer with sun protection factor every single day, because this damage is very cumulative, and we're seeing more and more skin cancers in these exposed areas. Okay, so now I'll talk about the most important one and the reason that we're here today. Malignant melanoma, as I mentioned earlier, accounts for only 4% of new cases of skin cancer, but accounts for more than 75% of skin cancer-related deaths. So this is the one that is very aggressive. It's very important to be familiar with so that we can detect them early and try to cure these people before the melanoma invades, spreads through the body. My colleagues, Dr. Berman and Pavlik, will talk about more advanced melanoma, but I'm trying to impart to you the importance of early detection, what to look for, and hopefully all of you will have a skin check every year so we can catch them early if they occur. So melanoma continues to increase in incidence. It's thought that over the past 50 years, there's been a 700% increase in melanoma. Some of this is because we're getting better at detecting it, so we're looking for it more and we're detecting more, but the incidence actually is truly still increasing. It was thought in the 1930s that about 1 in 2,500 Americans would develop melanoma, and the latest stat from this year is that 1 in 50 Americans will develop melanoma. So that's a staggering increase in incidence. It's thought this year, and this data is just out from the Skin Cancer Foundation, it's thought that this year about 9,500 people will die from melanoma in the United States. And again, of the 7 most common cancers, melanoma is the only one with increasing incidence. And so that really says something. So it's a true increase in incidence. Now, fortunately, the mortality is not increasing as much. So because we're getting better at detecting them, we're catching them at earlier stages more and more while they are still curable. But this is a real disease with real problems, so we want to be aware of them. On average, between men and women, in men it's 7th and women it's 5th, but melanoma is thought to be the 6th most common cancer diagnosed in the United States. What's interesting as far as the epidemiology of this disease is that up until about age 39, women are almost twice as likely than men to develop melanoma. And we think a lot of that correlates, again, with tanning habits, with exposure to indoor tanning salons. Then, after about age 40, and in that young age group, breast cancer is the only cancer more common than melanoma. After about age 40, the incidence in men takes over and surpasses the incidence in women, and then continues for the rest of life. And actually, it's older Caucasian men that have the highest mortality rate for melanoma. So the women, there's a peak in young women. Those melanomas tend to be diagnosed usually a little bit earlier, and then the men take over, and the men tend to be diagnosed at a later stage, often because they're not coming in to get checked, and their mortality is higher. It's thought 1 person dies from melanoma every hour. Again, it's the leading cause of cancer-related mortality in young women. So breast cancer is number 1 as far as incidence, but as far as cancer-related death, melanoma is number 1. Again, older Caucasian males have the highest mortality rate. Despite all this scary statistic, the good news is that if you catch melanoma early, the cure rate is very good. So if it's detected before it spreads, it has up to a 99% cure rate. So again, emphasizing the importance of early detection so we can remove them before they develop potential to metastasize. As far as what to look for, and this algorithm actually came up here at NYU in the 1970s as the ABCDs, and then about 7 years ago we added E, but the ABCDEs of melanoma. So A is asymmetry. Many forms of melanoma are asymmetrical. Unlike common benign moles, which tend to be very uniform and very homogeneous, a melanoma often has one side that doesn't look anything like the other side. B is border irregularity. So again, common moles tend to be very smooth and have very round borders. If you look at the border of a melanoma, it tends to be jagged or scalloped or maybe a notch in it. So that's an indication for a biopsy. C is color variability. Again, benign moles, often, there are some exceptions, but often they're very uniform in color with maybe light brown, dark brown. Once you start to see varying shades of brown or even black or white, which can indicate regression, or red, any mole with a lot of different colors definitely needs a biopsy. D has kind of fallen out of favor a little bit because we've gotten better and better at diagnosing smaller melanomas, but A, B, C, E wouldn't work so well, so we keep the D in it. But D is diameter. So we used to think that moles that were very large were more likely to be melanoma. Now that might still be true, but you can certainly see the other changes in much smaller moles. Personally, I've diagnosed melanomas as small as 2 millimeters in diameter. So, we have aids that we use. Dermoscopy is a tool where we'll use a magnifier to look at moles. So we've gotten better at seeing features before they're large. However, if you do look at someone and they have a lot of small moles and there is one that's expanding or is larger, that is an indication that it could possibly be a melanoma. And then E, which is the most recent addition, E is evolution. And so most importantly, if a mole has changed, so this is either if a doctor notices that it has changed, Or if a patient comes in with a lot of moles and they say, this one has changed, I will definitely take it off, because patients are often best at detecting something subtle before we might even pick it up ourselves. There's one type of melanoma worth mentioning called nodular melanoma. Nodular melanoma doesn't obey some of the other rules because it tends to be very uniform in color, but that color tends to be black. It tends to be a very aggressive type, so it might just come out of the blue one day as like a new, very dark, raised bump on your skin, and that type of melanoma is the most aggressive because it invades very rapidly. So like a very dark new spot should definitely be evaluated. Something worth mentioning, African Americans who also can get melanoma tend to get more melanomas on the lighter skinned areas of their body. So the palms, the soles, even the mucous membranes inside the mouth. These are areas that African Americans have a particularly high risk for getting melanoma. And I always tell people Bob Marley actually died from melanoma. So that shows that, and he was 38 when he was diagnosed, I believe. So he was young, he was darker skinned. So clearly everybody needs to be checked, including the bottoms of your feet. Advanced melanoma, these are pictures of classic advanced melanoma. Again, we've gotten better at detecting them before they get to this point, but this is how they might look. So Dr. Berman's going to speak after me about the treatment of melanoma, and he'll talk about surgical excision. But the one thing that's really important to know is that prognosis for melanoma is directly proportional to how thick the melanoma is. And we're talking like fractions of a millimeter in thickness. So we're not talking about the diameter on the skin. We're talking about, if you look under a microscope, how invasive is that melanoma. And if they're very thin, the 5-year survival rates are very good. So melanoma in situ is like the very top of the skin with no depth. That's considered stage 0 and has an excellent cure rate. Once it starts invading down where they have access to blood vessels and lymphatics, the cure rate continues to drop. So it's thought that the cure rate is very high for thin melanomas, and once you get to over like 4 millimeters in depth, the prognosis drops precipitously. So again, the key is early diagnosis and treatment. And I'll let Russell talk about that. Just something I want to point out that's different about melanoma. We know that sun exposure is associated with all types of skin cancer. However, as I mentioned earlier, basal and squamous cell carcinoma are more common in people that chronically spend a lot of time outdoors. They occur most commonly on chronically sun-exposed areas. On the other hand, melanoma is oftentimes associated with people that get intense bursts of sun exposure. So they tend to occur, for example, on areas that are normally covered, and then when they go on a sunny vacation to the Caribbean or to an indoor tanning salon and they get these short, intense bursts of sun exposure, those areas are more susceptible. I mentioned the farmers don't get as much melanoma. Areas like the backs of the hands and the face that are chronically tanned, it's oddly protective. They don't get melanoma, but areas that are covered and get intense sun exposure are at higher risk. People with numerous moles are also at risk for melanoma because the moles themselves can progress to melanoma, and it's also a marker that they're at higher risk even in their normal skin. And again, we mentioned the use of sun tanning devices. So this is just a picture of someone with dysplastic nevi or atypical mole syndrome. As I mentioned, these patients, these moles can turn into melanoma themselves, but even their normal skin is at higher risk for developing melanoma. So these people need to be seen at least twice a year to get checked. Sunburns are definitely, again, it's not the chronic sun exposure, it's the acute blistering sunburns. More than 5 sunburns at any age doubles your risk for melanoma, but even 1 blistering sunburn during childhood or adolescence doubles your risk for melanoma later in life. And as far as sun tanning devices, we know this is a huge problem and it largely accounts for the peak that we see in young women, but the first exposure to tanning beds in youth increases your chance by 75%, so that's staggering. Most patrons are female, age 16 to 29, and then as I mentioned, we're seeing more and more basal and squamous cell carcinoma in this younger age group as well, so we know that the sun tanning salons are also causing basal and squamous cell cancer, in addition to melanoma. Ultraviolet radiation was upgraded to the highest cancer risk category by the World Health Organization, so it's joining as the highest category arsenic, cigarettes, and mustard gas. We know that ultraviolet radiation is linked to more cancers than any other carcinogen, and the rates of unprotected sun exposure shockingly remain high despite this link, so we have to get better about protecting ourselves. I'm going to skip through this, but the bottom line, when I can't tell people that the threat of skin cancer is enough, I at least try to appeal to their vanity, because we also know that 90% of the signs of premature aging of the skin, so sunspots, wrinkles, uneven texture, uneven pigment, is also caused by sun exposure. The American Academy of Dermatology suggests that regardless of your skin type, a broad spectrum sunscreen with at least SPF 30 should be used year round. Even on a cloudy day, 80% of ultraviolet rays pass through the clouds, and they do penetrate through car windows and office windows as well. So I tell people they really should get in the habit of wearing it every day. And of course, sun has high reflective powers, so the skiers. Wearing sun protection every day, because the rays can penetrate through clouds, through windows, through the car windows. So people often say, I wear sun protection when I go to the beach. I'm not in the sun otherwise, but the point is these rays can get to your skin every single day. So what can you do to protect yourself? Contrary to popular belief, only approximately 23% of a person's lifetime sun exposure is acquired before age 18. So it's not too late. I hear people all the time say the damage is already done, I wasn't so good, but it's definitely an ongoing process. And there was a study a couple years ago that they looked at adults, and regular users of sunscreen starting in late adulthood reduced their incidence of melanoma by 50 to 73%. So it's definitely not too late to be careful. You want to avoid peak hours of sunlight when the rays are strongest. Again, a daily sunscreen, SPF 30 or higher. I always tell people too that clothing is even better than sunscreen. Too often I see people come back so tan after vacation and they say, but I wore sunscreen. And that's because they put it on and still lied out in the sun. So again, staying covered up and staying in the shade whenever possible. Teach children sun protection early. So my kids think their sun shirt is like part of their bathing suit. This is literally in Florida a couple weeks ago, our 2-year-old daughter. But the thing that made me most proud is my son, who in this picture was about 6 on the right, but this is at sleepaway camp last summer, and I was not there. A photographer took the picture. So it's good to see that he thinks of when he goes swimming and his friend next to him clearly doesn't have one on, he puts his sun protective shirt on to swim in as well. Definitely avoid tanning salons, and sunless tanners are a safer option. They don't protect you, so if you like to be tan and you use a sunless tanner, that's fine, but make sure you use SPF on top of that as well. Get your vitamin D through a healthy diet, examine your skin regularly, and most importantly, if you notice any changes, see a dermatologist promptly for a biopsy, because skin cancer is preventable and curable when it's detected early. So thank you for your attention to the NYU Cancer Institute, Skin Cancer Foundation, and of course to Mollie's Fund. So thank you for being here.